Morning, everybody, and thank you, Dr. Somil. So, my talk today is miLOOP, the new way of pre-chop. So, these are my financial interests. So, it is a tool by which we can do the chopping before we start the phaco, and it is reduces the phaco power by around 30%, and also there is a reduction in the overall phaco time, the procedure time. So, it can be used in dense cataracts, compromised zonules, and Fuchs dystrophy, where we require some adjuvant for phaco. So it has got a, it's a single use nitinol loop. Okay, you can see the loop over there. Okay, this loop will constrict. Once you withdraw the piston, it will constrict and it will break the cataract into two pieces. Let us see a small animation. So it goes around, because of its shape, it goes around the nucleus very easily under the capsule, and you can, by first chop, you can divide it into two, and by the second chop, you can divide it into two more. That means total 4 pieces. Now let us look at the step-by-step guide. First of all, entry. We have to lie it flat while introducing into the antechamber and then introduce it. Take it on one side. If you are right-handed sender, take it to the right side slightly and start expanding. Let it expand under the capsule. As it goes under the capsule, just goes in slow steps so that it and you allow it to expand under the nucleus. So this is what is done, that it will expand under the nucleus. Over here, one of the most important thing is to look for silver reflex. You can see that a red mark is there. That is the silver reflex. That is basically the lower arm of the tinelar loop, which is coming. That has to come right below the loop in the antechamber, the part in the antechamber, and then only you go for cutting. Now, this is the way it should be cut. Now here, the second instrument is very important. When you are cutting, the nucleus can get lifted, and therefore the second instrument will help in keeping the nucleus down. Similarly, if you understand that the loop becomes a small one as you withdraw, but it does not completely close. So in the end also, very small piece is attached between the two heminuclei, and that's why you have to insert it again and withdraw, and that time the second instrument will help you in separating. So unless it is done, then you will have a mess of the things. So these are the various positions, the silver loops, specifically shown in immature cataract, how it will look, even though we hardly use it there. Exiting the incision, it has to be done same way, lying flat, and it comes out the incision. One thing I forgot is that on the shaft there is a black mark, and that is the point till which you enter it in the wound. Now let us look at a case. So this is a case of immature cataract, grade 3. However, there was compromised endothelium. Now you can see that silver reflex going there. Allow it to expand, and yeah, it goes. You can see that silver reflex now. And now second instrument comes, so that you don't allow the nucleus to pop up. And then do second maneuver again. Separate the two nuclei. Go on to the other side, again you do the rechop and complete the procedure. I'll just show you the part of the video, the phaco, so that you understand that how easy it is to do the phaco now. Yeah, so it is divided into so many pieces that phaco is really very easy. Remember, the most difficult part for any surgeon, cataract surgeon, is the first chop. If it is taken care by any instrument, let it be miLOOP, it will definitely have positive impact on the surgery. Now this is another case where it's a hard cataract. The first one, there were a lot of cortex, so you could not see it properly. That is the why this second case is shown. So hydrodissection, rotation of the nucleus to be really sure. See, lying flat, going entering in, and now we are expanding it slowly. Let it go underneath. Over here, the silver reflex may be muffled or may not be seen at all. Okay, and now the second instrument will come into play. Okay, so the chopping is done, and now the second instrument, the second instrument holding it. Second instrument can also be used to separate the two pieces, so that whatever that small attachment is there, that can be broken. So you need not do that maneuver of injecting and withdrawing again. And now this is the second part. We need not see that. What are the probable complications? It has a learning curve, but once you have done 10 cases, it is one of the easiest thing to use. CCC tear. Suppose we go while withdrawing. Suppose the small appendage between the two pieces is left intact, and we try to withdraw. It has got a capacity to either get the nucleus entirely into the anterior chamber or rupture of the CCC. Similarly, there can be floating cortex. So in a mature cataract, that is not much of a problem. But in the first case when I showed, because of the cortex started floating, it can make our view cloudy, and then we may have to re-inject visco and start operating. Okay. If the silver reflex rule is not followed, then we can get improper cut. So you get one piece big and one piece small, and of course you can have AC collapse. For that, it is very important that the instruments are not pressing on the posterior lip of the incision. This is the paper which says that 110 eyes were done, 58 miLOOP and other phaco, and there is a reduction of energy by 30%, 30%, and there is 20% less loss endothelial cells. Thank you very much.
Very nice presentation, sir. And while the next speaker, Dr. Alkesh Chaudhary, sir, will just set up his laptop, would just like to talk about in which cases would you do this as a routine, as a part of your surgery, or in which situations you would like to do this and which situations you would not do this?
Yeah, as I said, that the most stressful part in phaco surgery is the first chop. So whenever the stress is more, I would like to use it. So fuchs dystrophy, compromised zonules, and hard brown cataract. I would not like to make it a kind of a all case scenario.
And while you are getting that loop and actually chopping the nucleus, cutting the nucleus with that loop, there is a tendency for the chamber to become slightly shallow. So in such situations, when there are the exact situations where you would not like the chamber to be shallow, fuchs, endothelial dystrophy and things like that, so that every fluctuation or shallowing also adds on to the cell loss. Although in the study it has said that 20% less cell loss is there, but that is one point where anybody who's starting off should be wary of.
Yeah, actually very important. But I forgot to mention in the lecture is that once you get that silver reflex thing, after that it is very important that to move it slightly downward. So the direction, rather than let it be slightly like this, that will ensure that there is no the nucleus not getting lifted, neither there is collapse of the AC because of the egress of the visco from the main incision, and then you can say. So that's what I said, that it has got a learning curve, but about 10 cases and you are done, like you will do it properly.
Perfect. Thank you, sir. Thank you. Sir?
These maneuvers.
Yes, sir. Methyl cellulose.